This is my first time giving this talk to you all, but just generally speaking. And so at the end, I do have a slide for feedback. I would love feedback as I really do enjoy teaching, but it's not only going to help me, it's going to really help our residency program find content that you all find meaningful and valuable in your clinical practice. And so I know that some of my colleagues have given talks about difficult clinical encounters to the medicine residents in the past. I wanted to be more specific today and choose a particular topic within difficult clinical encounters, which is how do we set boundaries with patients, but with people in our lives. And I will say this was inspired actually by a medicine resident who in my intern year helped me set boundaries when I did not know how. Those are coming full circle. And so I don't have any conflicts of interest disclosures. A couple of objectives. So first and foremost, define what a boundary is, identifying the three different types or styles of boundaries, how the setting boundaries impacts our clinical interactions, and list factors contributing to difficult clinical encounters, identify when we should be setting boundaries, and then understand how to use them and how to apply them to a clinical case. So this is the interactive portion. I have several questions for you all. I'm curious, what is a boundary in your mind? What do you think of? What comes up for you when you hear the word boundary? And feel free to use the chat.
I would consider it a limitation of like things that are appropriate and not appropriate, or that an extent of effort that one is willing to participate in.
Yeah, I love that definition. It's pretty close in some ways to the one that I came up with. I will say this is not a definition that I plucked from anywhere in particular. It's just something I made up. But I've defined boundaries as expectations. So you said limitations, but very similar thing. Expectations that define behavior within a relationship. And so in this case, we're really thinking about the relationship between a clinician and a patient, but you can apply this to anybody in your life. You, your partner, you, your friends, you and the rest of your team. Just expectations that define behavior. Perfect. Why are they important? Why do we set boundaries with people? Or frankly, why do we set boundaries with ourselves? Oh, I like that answer. Have the bandwidth to give all patients the same level of care and have a personal life. I really like that. That is a great answer. And I agree with you. Really, boundaries are to be able to help us feel safe, help us feel respected, and to help us feel comfortable. And not just us as providers, but the patients too. It's really to make sure that everybody is safe and comfortable. And that's going to really translate to that emotional bandwidth that you're talking about and the ability to engage in things that are really meaningful and fulfilling to you. So this is a question I'm not going to pose to you because it's kind of a read my mind kind of question, but there are different ways that we can categorize boundaries. One way is to think about boundaries being intellectual, emotional, physical, etc. Another way is to really think about it on a continuum in terms of how we behave when we're setting boundaries. And so we'll start on the left side. Porous boundaries is one way to characterize this. And those are boundaries that are pretty weak. They're poorly expressed. People who set porous boundaries may identify as people pleasers, or they're just going to tolerate a lot more mistreatment than someone else might. This is also going to be the individual who sets a boundary and then later on does not actually follow through with it because they're too worried about what the other person is thinking. On the absolute other side are people who set really rigid boundaries. They're very strong, they're overexpressed. A lot of this is creating like a 10-foot wall between you and another person. And it's really to keep yourself safe, avoid vulnerability. You're gonna have pretty high expectations of another person. And when they don't meet your standard, you might kind of shut off and just leave the scenario. Healthy boundaries are in the middle. They involve really great communication. They involve emotional awareness, what's going on inside your body. And mutual respect. Really, the intent is to just be respectful and a clear communicator. What I want to make clear here is that there are people who lean to one side of the spectrum or another. Some people might find themselves in the middle, and we can kind of adapt the type of boundary we're setting depending on the other person. And so there may be instances in clinical scenarios where setting a porous boundary makes more sense, or setting a rigid boundary makes more sense. So that's something to keep in mind. So how do we know when to set boundaries? What I will say to all my questions is that there's no right or wrong answer consistently. Love that. Initially, yes, and then with challenging behavior. Perfect. You hit on exactly what I wanted to convey, which is that you can set boundaries at any time. And in fact, I encourage it. But there are particular encounters where setting boundaries can be really helpful, and I've just identified them pretty broadly. One would be an angry encounter. So on the psychiatry consult service, we see this a lot. Patients who become really upset, angry, agitated. This is really either verbal or physical. They may even be demonstrating unsafe behaviors. And so typically we come in at this point. Exhausting encounters. This one where we may not be thinking of necessarily because we may be attributing it to just burnout and the demand of the job. But there are scenarios where you're going to leave the room feeling really drained and really tired. And you may even wish that the patient would just fire you if you're in the outpatient setting. Sometimes these patients are going to have lots of demands, lots of clinical problems that they're bringing to you. They may be someone who is help seeking, help rejecting. They may come in with a lot of complaints, but you find out that they're not really adhering to medications. And this can really take a toll on you. And so boundaries here would really be helpful in working towards a common goal. And then healthy encounters. This is sort of the consistent with all patients. It's always helpful to establish boundaries with patients, even when things are going well. It's going to continue to promote a good relationship between you and your patient. And so, in thinking about factors contributing to difficult encounters, this is probably one of the more important slides, I would say, in the presentation. It is based on a couple of resources, but I've adapted it to sort of fit the model that I use in my mind every time I see a patient. And so we have to think about factors that are within the patient, factors that are within the clinician or the provider, and then factors that exist just structurally that are in some cases outside of our control. And we can kind of break these down into personal and interpersonal. So things that really are just to the person, and then things that are going to impact the way that you communicate with each other. And so for the patient, they're going to have mental and physical distress just associated with being in the hospital. And that's important to consider. They may not be acting their normal selves because they're hospitalized. And a lot of times you may see patients regress into a maladaptive coping system. And so they may start to split. They may start to behave in ways that are more childlike, all because they're under a ton of stress. There's a huge power dynamic that they experience too. They're vulnerable as a patient. They don't have the power that doctors or nurses or anybody else has, frankly. On the other side, the clinician, we're more prone to be dealing with compassion fatigue. And so just general exhaustion, burnout, our workload is really high. The hours residents work can be quite insane. And so that's going to apply more to us. What I really want to highlight here that I don't think a lot of resources highlight enough is that there are so many things that apply to both of us. And a lot of people make the mistake of just saying that psych conditions, substance use only apply to the patient. That is not true. Providers as well have psychiatric conditions. A lot of them have untreated depression and anxiety. It's important to be aware of that. There are providers who do have substance use disorders, either active or in recovery. Maladaptive coping applies to both of us. We can cope really poorly when we're under stress as well. And everybody is going to bring a personality into the room, some more than others. And so personality that really plays a huge role is cluster B, as I'm sure everybody is aware. But we also have to think about other personality factors as well. Interpersonal things, emotional dysregulation, help seeking, help rejecting. I've talked about that already. For the clinician, we really have to be aware of our biases or stereotypes of patients. Do we get defensive when patients challenge us? Are we distracted? Is there other things going on that's making it difficult for us to be in the room with the patient? And are we just focusing on the patient's weaknesses and not enough on their strengths? Can we find a strength and use that to make communication better? Things that are going to apply to both individuals in the scenario: racism, microaggressions, just poor communication and not checking in with each other enough about how things are going. And then structural, again, patients who are victims of racism may be bringing that into the room. And it's important to be considering that when you're seeing patients of color or of a different culture than you. Both people, if you're in a difficult location, in the ED, in the ICU, these are really terrible places to be having great conversations. And all of that can make an encounter difficult. Culture and language barriers, again, make it difficult. And for us as providers, we're kind of constrained by time. And it's really to no fault of our own most of the time, but there are a lot of sort of systemic things that are permeating down that are going to affect encounters. All right, so this is another question posed to the group. What makes it difficult to set healthy boundaries or just set boundaries in general? If you can think about a time where a boundary would have been helpful with a patient and it was difficult for you, what kind of came up? What was really hard about that?
I think we all really want our patients to like us, and having any degree of confrontation is challenging.
Yeah. Or a process in the patients that are fun to talk to. Oh, I love that. Yeah, I hear that a lot, that it is difficult to set boundaries because we want to be liked. And we're, I think, in a time of medicine where we are rated by our patient satisfaction. Therapeutic alliance, yeah. Tough because you get frantic messages via my chart. Yeah, these are all really great responses. I'm going to dig one step deeper because I am a budding psychiatrist here, and dive into really what goes on at a deeper level. And so some things that can come into the room that make it difficult to set boundaries are just our previous experiences and our upbringing. And a question to really ask ourselves is, were boundaries set when we were kids? Yes, I'm going to go back to childhood. Were boundaries set when we were kids? And were boundaries respected when you were a child by your caregivers? And if they weren't, how does that influence the way that you're able to set boundaries today? Next will be attachment style. And I know that us in psychiatry are more familiar with this terminology, so I'll explain it pretty briefly. It's really a theory that defines how we interact with other people in our adult life based on the interactions and relationships we had when we were kids, though we know that attachment style is sort of changeable, this is the word I'm looking for, as we age. And so important relationships in our adult life can change our attachment style. For the purposes of this, we could think, are we secure in our attachment or are we insecure? And securely attached people really are going to be trusting of others. They're not going to be particularly cynical. When things difficult happen, they sort of have this compassion and understanding about it. Insecure attached people can be very anxious and really worry that somebody doesn't like them or that somebody is going to hurt them. They may bottle up and put walls up and exit important relationships because they're too afraid of that loss. And so it's important to think, is our patient secure or are they insecure? How is that influencing the way that they're talking with me? And how does my attachment style influence the way I'm talking to them? Confidence. Have we done this before? Do we know how to set boundaries? Is this something we feel comfortable doing? And if it's not, that could certainly make it difficult. Culture. So really, again, bringing into our own culture, what was it like growing up, but the workplace culture. Do you see other people setting boundaries or would it just be you? And does that feel kind of appropriate or not? And then lastly, again, power dynamics. It's much easier to set a boundary with someone who is of perceived less power than you. And so sometimes patients can have difficult time setting boundaries with their providers for this reason. So this is a pretty quick question, but who can set boundaries? Anyone? Yes, perfect. Everybody can set boundaries. And so your patients can set boundaries with you. You can set boundaries with them, nurses, just any staff member, frankly. You can set boundaries with everybody in your life. And I hope that what you can translate from this today is that all of this information applies to everything. It's not just the clinical space. And this is a question that I wanted to ask because I've noticed in medicine, at least my time on medicine, that a lot of medicine folks have kind of toolbox phrases that they use when they need to set a boundary or when they witness a microaggression or when they witness something that's kind of unacceptable. And I'm curious what phrases you use, if any. And I'll put up an example of what I'm talking about. These are some of the things I've heard before, which is, I'm surprised you would think this behavior is acceptable. Or in psychiatry, we do this a lot, especially with patients who experience delusions. We don't seem to be agreeing on this. And I feel like this conversation isn't really productive right now. So I'm going to leave. I'm going to come back when we're feeling a little calm and we'll talk again. This is one I use, especially with my psychiatry patients who are in the midst of mania or psychosis, and they're being not very nice. I will say that I understand you're not feeling well, and this behavior is not accepted and won't be tolerated. It's not tolerated by the institution, and it's certainly not tolerated by us. I'm going to leave, and I'll come back when you're feeling a little better. Do you have other phrases, or does this kind of sum up what you all use? I'm going to assume that maybe this sums it up. And just for the all right. So now I want to talk about communication tips for boundaries and sort of the algorithm that I use when I set boundaries with patients. I sort of just analyzed what I've done and what works for me. I also looked in the literature. There wasn't really a guide. And so I thought it might be helpful to give you all a guide that maybe you might find helpful in setting boundaries with patients. So whenever I am in a difficult clinical encounter, I always want to follow these steps. Usually, well, I don't know why number 6 is a little crazy here, but I try to follow these steps to some degree. It may be in order, maybe a little bit out of order, but it usually follows this. And when I'm talking about difficult clinical encounters, in psychiatry, I'm really talking about the patients that are yelling at me, but you certainly see this on the medicine floors, or you'll see this in the outpatient setting. Patients who express a lot of needs, and a lot of it's kind of coming from this internalized sense of anxiety or insecurity. Patients who won't let you get a word in edgewise. And so it's helpful to figure out where is this coming from. And so the first thing I always do with a patient is try to explore their goals. What are their goals for their health and their goals for their recovery? And I will ask them this question: what are your goals? Is it to get out of the hospital? Is it to feel better? Is it to see your grandchildren next week? Is it to go home for Christmas or the holidays? What do you need by being here today? And the next thing I want to do after I do that is explore their emotional response. And I'm really thinking behavioral, psychological. I'm also thinking about my own emotions, my own physical safety. I'm taking all this into account. And it will be sometimes easier for me to figure out what they're experiencing because they'll say it out loud. They'll tell you, I'm angry or I'm really upset. I don't feel like you're hearing me. And then I'll reflect to them. It sounds like you might be feeling X. Did I get that right? And I tell all of my medical students, if you get it wrong, the patient is going to let you know. And it is okay to be wrong. And then I'm going to validate, but only validate what's valid. And so in this case, thinking about maybe patients who are demonstrating really unsafe behaviors, you can tell them, it's totally understandable to me that you'd be feeling really upset and angry right now. And then we move on to the expectations. However, physically harming staff is unacceptable. It's not aligned with the values of the hospital or the individuals who are attempting to help you. When you're setting expectations, if you can add the rationale for that expectation, it will be better received by the other person. After you set the expectation, you want to let them know the consequence. If we don't set a consequence, you're really just threatening them. And so patients might say, when you set a boundary, are you threatening me? And this, no, I'm setting a boundary. I'm being firm with my boundary. I'm giving you an expectation. And here's the consequence. If you continue to engage in unsafe behaviors, we'll leave the room and we'll come back only when you can be calm and safe. In emergency situations, this may not always be possible, but in most cases, this is possible. And then you want to assess their understanding. Did they comprehend what you said? So can you tell me what you understood about what I just said? And then connect. So you want to connect what you've just said back to their goals. And this might be, in my mind, the most important part. So I've told you now the boundary, and I want to connect it back to what you said. So you've expressed to me that you want to discharge from the hospital as soon as possible, and I hear you. Following this guideline for behavior will help you meet that goal faster. It will help you get out of here sooner. And that is really going to instill this sense of autonomy and power back into the patient, which again, if we think about all those patient power factors, the power dynamics, the institutionalized racism for a lot of patients, the insecure attachment style, the mental illness, giving them that power and autonomy back is going to be really important and really helpful to them. So this is what a sample boundary might sound like. And this is what it sounds like actually when I talk to my patients. So I just wrote out what I would say. I would say something like, it's understandable to me that you'd be feeling pretty frustrated and powerless right now. And the and is important. You cannot verbally harass the individuals who are trying to help you. If you continue to verbally harass the staff members here, they will walk away and they're only going to come back when you're able to communicate calmly and with respect. Can you tell me what you understood about what I just said? And so patients who may be delirious may not be able to respond back, but that's a different situation. It's helpful though, just keep reiterating this with the patient. If it doesn't stick the first time, hopefully it will stick later. So there are a lot of normal responses after you set a boundary, and it's important to think about that. Patients may test limits of boundary setting. And so after you set the boundary, if it's pretty clear enough, they'll engage in behaviors to escalating degrees to figure out where that line really is. They may ignore it altogether. They may push back and be really defensive and say, I didn't do what you're saying I did. I did it because of this. They may get pretty defensive. And they may rationalize. Alternatively, they may just accept the boundary and follow it. I'd like to say that that's probably the least likely scenario. It's important to know that all of these are normal. We do this too when boundaries are set with us, and it's important to reflect on that. How do I respond when people set boundaries with me? Is it really hard to follow it? And why? So just having some compassion for the patients who are not feeling well, and continue to set the boundary with them. Just try again and again. And you can think about, if a rigid boundary didn't work, maybe I have to move over to the other side of the spectrum, or vice versa. And so I have a little case in the next couple of minutes here. And the case is somewhat interactive and hopefully realistic enough for you all. As we move through the case, I want us to be thinking about emotions that come up for you if you can place yourself in this clinical scenario. So what are you feeling as you're talking to this patient? What factors that we talked about before and that kind of wordy slide contributed to this being very difficult? So we really want to be thinking about patient factors, provider factors, situational, systemic, all of that good stuff. So here's our case example, and I want to start by saying that this is a resident team. So we have a senior resident, an intern, and some medical students who are going to see Mr. John Doe. He is a 68-year-old divorced, housed male. He has a past medical history that's pretty complicated, but not unfamiliar to you all. So he's got type 2 diabetes. His A1C most recently is 10.5. He has HFrEF with an ejection fraction of 45. Chronic pain that is mostly attributed to lumbar stenosis and osteoarthritis. He has a history of opioid use disorder. He was previously on methadone, and he was admitted 5 days ago for septic bacteremia secondary to osteomyelitis of the left hip. During the course of his admission, Mr. Doe has been waxing and waning in his mental status, which has been pretty concerning for delirium. And he's had lots of agitation, both physical and verbal, that really is just not responding to low-dose antipsychotics. He has been observed to verbally harass nurses, and he's attempted to hit people that are trying to care for him. And most of the time when this is happening, he's saying that his pain is not controlled and he just can't sleep. He's really frustrated. Current pain regimen includes Tylenol, diclofenac, lidocaine. So he came from the ICU to the medicine service. Now he's on acute care medicine, and we're seeing him for the first time during morning rounds. And before we go in, his nurse catches us as we're about to go into the room and said, hey, he tried to squat at me and tried to hit me when I was trying to change his linens. He did have an episode of urinary incontinence overnight. And when I attempted to help him, he screamed at me and said, I can take care of it myself. I don't want your help. And we consider that as we're going into the room, and he appears alert and oriented, ×3, alert and oriented to person, place, and situation. Not really quite sure what time it is or what day it is, but he does know the year. After introductions, he demands to get pain medication right now. And he's saying that everybody's ignored him. All of the doctors are idiots and they left him to die in misery. And we're trying to get some more information about his pain, but he just won't let us talk. He interrupts and he says, didn't you hear me? I'm in pain. Get me a real doctor. And while you're at it, find me a different room. I want a window. Apparently he doesn't have a window. We're just not fine. So he terminates the interview. He does not want to talk. He wants you to go out there and give him some pain medication. And so this certainly looks a whole lot like patients that I have been involved in caring for in the past. It's not any particular patient, but I want you to think about what emotions come up for you when you have patient encounters like this, where patients are a little bit more upset and angry and agitated. What do you feel inside your body, both physical sensations, but also emotions? What comes up? Frustration, dread. Does anybody notice their heart starting to pound, their blood pressure rising? Heat, yeah. All the time this patient will take, yeah, pretty stressed out. Is anybody like, let me go call psychiatry right now, I can't deal with this? I think all of those are great responses. What factors might be playing into this? There's a couple that I want to highlight. But what really is coming into the room and making this really challenging? I wonder if people are, past experience feel like it's difficult to come to an agreement. Yeah. There's a couple of things about this situation that I want to call out. Yeah, just hard to talk to them when they're feeling like this. So how do we de-escalate this situation? Taking it personally. Yep, time constraints make it so hard. Exactly. Yeah, all really phenomenal answers. And yeah, love it. I think a couple of things I do want to add to this case oh, yes. Racism, sexism, ageism, get me a real doctor. Yes. So really feeling sort of these underlying, all of what you've said, racism, sexism, ageism remarks in what this patient is saying. Great. Is there racism, sexism, ageism on behalf of the provider when we're thinking about this patient and feeling frustrated? Does that come up? I intentionally did not tell you the race of this patient. And I'm curious, I didn't tell you the race, but did a patient come in mind? Did you visualize somebody? And that's not something you have to answer, but it's something to think about. Factors that are important to consider here are, we'll just start there, are the race of both the provider, but the race of the patient, the culture, the sex, the age, all of these things are coming into the room from both sides. And it's important to think about, do I get more frustrated with patients that don't look like me? That's important to think about. Do I get more frustrated when patients don't have the same background as me? Are they frustrated because I don't look like them? And they're like, oh, this again. You're just going to treat me like every other white doctor has. Or, you're a doctor, you have lots of money. You have no idea what it's like to be me right now. You've never had an opioid use disorder. You don't know what this is like. There's assumptions kind of coming from all sides. And that's another factor too. This gentleman has a substance use disorder and he's not being treated for it right now. Do we need to get addiction medicine in here? He was previously on methadone and he's not right now. Is all of this coming from the fact that he has an untreated mental health condition? Is all of this coming from the fact that he is just in the hospital and he has regressed into a personality that highlights what it was like for him as a child, where he wasn't listened to and he wasn't taken care of, and he needs to shout because he feels that no one will pay attention to him? All of these are things that I think about as a psychiatrist when I walk into a room, but certainly may not be the first thing on your mind as medicine folks. And many of you are going to go into specialties, but it's just something to kind of tuck back there. The next question is obvious. Are there opportunities to implement boundaries? If so, where? Yes, plenty of opportunities here. And I think there are opportunities at a bunch of different levels. One would be verbal agitation and really speaking calmly. And again, trying to figure out the goal. The goal here is pain control. And so just saying, I hear you, I hear that you're in pain and I want to help you. And it is easier for me to hear you when you talk in a quieter voice. Tell me about your pain, what's going on for you. All of those things can be helpful. The next would be unsafe behavior. I hear that you're really frustrated, you're angry, things are not being taken care of the way that you would want, and you can't hit people. That won't be tolerated here. So important to set that boundary as well. There are other areas that you can set boundaries to. And he set a boundary with you. He said, I'm not talking to you until I get my pain under control. How might you establish boundaries with this patient next time you see him? I sort of answered that. There's a couple of ways that you can do it. Is there anything that you would add to what I said? Any phrases that you might use in talking with this patient or that has been successful in patients like this in the past? And I'll just lump in the next question too. What's going to be really hard about setting a boundary with this patient? Delirium won't help. Yeah. Figure out what's causing the delirium. Help get him thinking a little bit more clearly. Exactly. And this might be one of those scenarios where the first time you set a boundary, it's probably going to fail. and that is okay. We just try again. And it's important that when you set the boundary with him, that you keep that boundary. If you say that you're going to walk out when he's yelling, it's really important that you turn around and the whole team leaves when he is yelling to let him know, I was being serious. This is the boundary that I have. This is how we keep each other safe. I want to hear you, and I can't do that if you're screaming at me. Okay. So, as we conclude here, I just want to talk about some quick tips. Setting boundaries does become easier if you practice it. A lot of times people might come into residency feeling pretty unconfident about setting boundaries with patients. We're just trying to get our feet planted firmly on the ground. There's a lot going on. Setting boundaries with patients might be on the last of our agenda, but doing so will promote healthier patient encounters over time. And so the more you do it, the more you're likely to find a style that works really well for you. So what I said here today works really well for me, and I've seen it work really well for other people, but it might not be your style. That's totally okay. The more you do this, the more you're going to be successful. Unfortunately, though, successful boundaries are not going to work for everybody. There are some patients where it does not matter how many boundaries you set with them, it will not work. And I see this a lot, especially in psychiatry with patients with neurocognitive impairment. Setting boundaries with them it's really going to be ineffective a lot of times because the frontal lobe of their brain is just not working right. And it's important to have compassion. The part of their brain that is really rational is failing them. And so setting boundaries might work sometimes, setting boundaries might not work other times. And so again, trying to keep yourself and staff safe, try to do your best to set the boundary, understanding that it just may not stick. You can, after it fails, reflect what boundary style did we use? Were we pretty porous and we didn't follow through that first time? Were we overly rigid? And did that turn the patient off? Did they get more upset with me because I was too strict with them? And then I made them feel like I wasn't hearing them. After everything fails, if that doesn't work, just practice self-compassion. And that is easier said than done. Try not to take it personally. There is a lot going on. And that was sort of the point of this talk that really influences things being super hard in setting boundaries with a patient. It is okay to say to yourself, this is not my fault. I did the best that I could. And it's okay. It is okay. When in doubt, always come back to the patient's goals. Again, trying to give them that sense of autonomy. And a bullet point that I didn't add that I think is really important to talk about is that it's going to be hard to engage in these difficult clinical encounters or set boundaries with patients or with anyone in your life if you are not feeling well. And I mean, if your mental health is suffering, if you are burnt out, if you are stressed, doing this is going to be infinitely harder. As much as you can, take time to take care of yourself. That is impossible or near impossible in residency all of the time. Find 2 or 3 things that you can consistently introduce into your life that make you well or promote your well-being. 1 to 2 things, that's it. It could be a 10-minute journaling, a 10-minute walk, petting a dog, watching a YouTube video of fluffy animals, anything that makes you feel good and can recenter and ground your brain. That will make you more successful, believe it or not. So that is all I have. So my resources. And I do have a slide with a QR code if anybody is interested in giving feedback. This would be really helpful, not only for me, as I said earlier, in making this more meaningful for you all, but will help my colleagues as we continue to give talks to you. I'll just kind of leave that slide up for a minute. You know, the audio probably pretty busy. It's getting to be that time of year too. Things are tough during the holidays. Happy to answer questions too if anybody has any. Right. I don't know. If you want me to stick around, I can just leave the slide up, or I could just email it.
Yeah, if you would like to email this to me, I'm happy to send it out so that if folks have not yet captured this QR code, they can. But I think maybe we'll give people like 1 more minute if anybody else has questions, and then we'll let you get on with your day.
I want to protect everyone else's time too.